Hi, everyone, and welcome to our IVF webinar. Once again, it's amazing to be back here with another special guest and specialist, and we do have an interesting topic to discuss. Thank you already for joining us tonight. I hope you had a nice Friday, and I'm always happy to have you here and spend this evening with us, learning a bit more on, as you know, on various topics. But tonight, as you can see, we will talk about non-invasive prenatal testing. So, of course, we have a presentation on that. And actually, our presenter tonight is Blanca Rodríguez. You can see her right here. Blanca, how are you feeling tonight? Thank you for joining our initiative here.
It's really nice to be here. Thank you very much, Caroline.
Thank you so much for joining us. And of course, I've already seen your presentation, so I'm sure it's going to be very, very useful for you and interesting. And let me just mention that Blanca, she is the genetics lab manager at iGLS, right? Which is a reproductive genetics lab, which is I would say, how do you call it? The IVF Life Group. It's like a part of the IVF Life Group, and it has been created there, right?
Yeah, that's correct.
Excellent. Thank you so much indeed for joining us tonight. And well, I guess let's not waste any more time, okay? And let's focus on our presentation tonight. But I also want to remind everyone that we will be able to answer some of your questions. So as always, type the questions in the chat section. And after we finish the presentation, Blanca will definitely answer them for you. So anything that you have on your mind, you know what to do then. And yeah, let's go ahead with our presentation then, Blanca, okay?
Okay.
Thank you so much.
Okay, first of all, thank you, Caroline, for inviting me to present this webinar. As you said, my name is Blanca Rodríguez Estrada. I'm a genetic lab manager at iGLS, which is based in Alicante. And I'm going to talk about the non-invasive prenatal testing. Well, the NCBI definition for prenatal testing is the determination of a pathological condition or illness in embryo after implantation, fetus, or pregnant woman before delivery. In these terms, prenatal testing offers a better management of pregnancy. Knowing the risk of a pregnancy, of a certain pregnancy, of having the most common fetal conditions, allows a risk-adapt monitoring. Sometimes the effects of these conditions, for example, cardiovascular or digestive malformations, may be solved by in-utero treatment. And last, in cases when fetal or mother's life is compromised, pregnancy termination may be an option. But how to know the risk of a pregnancy? For this, it's crucial to pay attention to the patient's medical history. Has the patient had previous miscarriages? And if so, were these miscarriages studied? Has the patient a relative that suffers from a genetic condition? Moreover, maternal age has been proved to be related with an increase of embryo aneuploidies. On the other hand, imaging techniques help the clinicians, giving them an approach to fetal phenotype. And also, there are biochemical factors that can be markers of normal or abnormal pregnancies. And last, the sample collection of fetal material and its analysis is the most feasible approach, but also until the NIPT, the most invasive. Well, it is known now that the majority of pregnancies are lost before delivery were carrying an aneuploidy. The aneuploidy is a status of having an abnormal number of chromosomes, which is 46XY or 46XX. This graphic represents the prevalence of chromosome aneuploidies detected during pregnancy, and as you can see, more than 50% are due to trisomy of chromosome 21, which causes Down syndrome, followed by trisomy of chromosome 18, and also it's an important number of the miscarriages are caused by the Turner syndrome, which is 45X0. Although they are not related with miscarriages, microdeletion syndromes have a major impact on fetal development. They are caused by small fragments of DNA being lost during cell division. Here you can see the most common syndromes, microdeletion syndrome, sorry. It's important to note that even they are the most common ones, they are not that common. For example, the George syndrome is present in 1 of 4,000 to 6 and 400,000 pregnancies. Well, let's have a quick review of prenatal testing a long time. Prenatal screening has been historically based on invasive procedures. Amniocentesis was first introduced in 1966 when Stillenberg proposed the introduction of a needle through maternal abdominal cavity to extract amniotic liquid that would be tested. Another invasive test was developed in the following years, consisting in a biopsy of chorea bilious, which is choriocentesis. The disadvantage of this technique of choriocentesis is that it implies a high risk of maternal contamination. These two invasive procedures imply culture of fetal sample and following cytogenetic or molecular tests of its DNA. More recently, the first trimester screening was introduced, allowing a first non-invasive approach to the pregnancy, and it has to be performed between weeks 11 and 13 of pregnancy. Well, the first trimester screening is based in a maternal blood test and an echography. Within the maternal blood test, two main hormones are normally tested: the beta HCG, human chorionic gonadotropin beta, and the PAPPA, pregnancy-associated plasmatic protein A. However, it has been noted that other hormones such as alpha-fetoprotein or placental growth factor have been included in some countries as co-markers. On the other hand, echography is a helpful tool to follow up a pregnancy. In this case, some markers can be measured to help the screening, like body length, measuring the length between the head and the end of the column, nasal bone, the presence or absence of this nasal bone and its length, the nuchal translucency, that measures the fluid area between the skin and soft parts in cervical bones, that it's increasing in trisomies of chromosomes 13, 18, and 21. And then the first trimester screening measures at least these two hormones, beta HCG and PAPPA, and the nuchal translucency. And this allows the calculation of a risk at weeks 11 to 13 of pregnancy. This calculation results in a classification of the patient in groups of risk. It is important to note that these groups may change between countries because every health system makes its own calculations based on incidence. Here we have an example of Spain public health system in which patients are divided in 4 groups depending on their risk. The first group of low risk does not need an additional test. Then the medium group can be offered to perform an NIPT. The high-risk group, which includes patients with risk 1 in 11 to 1 in 250, is indicated to perform either an invasive procedure or an NIPT. And last, the critical risk group, patients with risk higher than 1 in 10 are indicated to perform without any other step an invasive procedure. As you can see, NIPT has been included in most of the screening plans as a step to perform before an invasive procedure in certain groups of risk. Well, NIPT is based on the presence of fetal DNA in maternal blood. In 1997, Low and colleagues discovered the presence of cell-free DNA in maternal circulation. This was the first step of a wide range of projects trying to study fetal DNA in maternal blood until NIPT was developed. So I said cell-free DNA is a DNA of fetal origin released by the lysis of apoptotic cells from the placenta. Placenta is a permeable structure that allows the interchange of blood between the mother and the fetus. Cell-free DNA enters the maternal vessels and starts circulating in maternal blood. This DNA increases with gestation, and it can be detected since week 5 or 6 of pregnancy. Cell-free DNA offers us a non-invasive way to access fetal DNA. Moreover, it can't be detected after delivery, so there is no DNA from previous miscarriages or pregnancies in maternal blood. Cell-free DNA has a different size from maternal DNA, and they also have different DNA signals, but with the available technologies, we can't separate them. It has been proved that the presence of fetal DNA increases from a 10% in 10 weeks of pregnancy, and this increase can be calculated. The other 90% in 10 weeks of pregnancy in blood will have been come from maternal cell lysis. Well, for NIPT, we first need a blood extraction. Blood must be collected in a strict cell-free DNA tube, a special tube that prevents maternal cells from lysis and preserves fetal DNA. This blood sample has to be treated to isolate the DNA, and it has to be amplified. Afterwards, DNA is evaluated searching for aneuploidies or microdeletion syndromes. There are two methods developed to perform NIPT. The first one is next-generation sequencing. In this process, after DNA extraction, the whole genome is amplified and sequenced. The amplicons are aligned with a human sequence reference, and the reads are counted. This count is used by a math algorithm to calculate the risk. The other method is the SNP-based NIPT. This is a technique based on the study of concrete regions of genome that are highly polymorphic, which are the SNPs, single nucleotide polymorphism. These SNPs are used to create patterns among individuals to identify them. In this case, it is necessary to extract from both parents' DNA and isolate it and amplify their SNPs. The same is done with the cell-free DNA from a strict cell-free DNA tube. The parent SNP pattern is compared to the cell-free DNA one, and the copies of each chromosome are calculated through a math algorithm that allows to know the risk. Well, how does NIPT work? NIPT is based on the concept of fetal fraction. Fetal fraction is the proportion of DNA that has fetal origin from all the DNA found in blood. The fetal fraction depends on BMI, gestational age, and the presence of aneuploidies. It's this point, the presence of aneuploidies, which is the clue for NIPT. As previously said, aneuploidies and also microdeletions cause a variation on fetal fraction. NIPT uses fetal fraction to calculate the risk of them. Having a genetically normal mother, we can assume the fraction of maternal DNA is constant, and the variations are due to fetal number variation. This is used by a math algorithm to calculate the risk. This example represents a profile with an increased risk of chromosome 18 trisomy, Edwards syndrome. Here we can see that in red the copy number variation of the mother is constant. The representation of mother fraction of mother DNA fraction is constant, and then in chromosome 18 it's an increase of fetal fraction, which is due to the trisomy of chromosome 18. Well, fetal fraction can be a marker of either aneuploidies and copy number variations. Copy number variations are the ones that cause microdeletion syndromes, as the ones that we have seen in our previous slide. It's important to note that NIPT is a screening but not a diagnostic test. That is why the results are based on risk. High-risk results should be confirmed by invasive procedures. A low-risk NIPT does not need any other procedure than a normal follow-up. Here we can see the performance of the test when compared with other prenatal tests. NIPT not only offers a false positive ratio lower than the first trimester screening, but it also has a diagnostic ability that equals the invasive test. This means that the 99.9% of the results obtained by NIPT are confirmed with other tests. Well, but which are the limitations of the test? First and most important, like I said, is that this is not a diagnostic test, and a positive result should always be confirmed by amniocentesis or choriocentesis. Also, it is needed enough fetal material to perform NIPT. And also, a third source of DNA may be a limitation in NIPT, most when using a SNP approach. Well, the advantages of NIPT, the first and most important is that there is a non-invasive way to study fetal DNA. We can approach DNA instead of phenotypes, so we can avoid the need to detect rare phenotypes that are not well described. And also, it has a high positive predictive value, which is the number of positive results that are real positives when used as a second test. I will now give you a quick view of the test that we offer at the iGLS, which is SAFEBABY. SAFEBABY is an NIPT test that uses NGS technologies to detect high-risk pregnancies. The test can be done since the 9th week of pregnancy, and it requires a minimum of 3.5 fetal fraction. The NGS technology makes the test high sensitive and specific. Okay, here are the advantages and the numbers of the SAFEBABY. For chromosome 13, 18, and 21, the sensitivity of the test is higher than 99%. Sex chromosomes abnormalities can be detected with a sensitivity higher than 83% and a specificity higher than 99.9%. The autosome sensitivity goes from 95 to 99% depending on the chromosome. And microdeletion syndromes can be detected when the deletions are higher than 6 megabases. And finally, to conclude the presentation, I would like to give you some take-home messages. First, NIPT is a non-invasive screening test, which means that it's not a diagnostic tool. And always a high-risk result must be confirmed through an invasive procedure. NIPT is highly reliable when testing most common aneuploidies as CMVs, and it's a really good complement to ultrasound monitoring. So thank you very much for attending this webinar. I will be glad to answer every question you have about this topic. Thank you very much.
So much indeed, Blanca, for amazing presentation, and of course for explaining and giving those take-home messages as well. Definitely useful. Yes, and now it's your favorite part to do. Okay, so it is Q&A session time, and as you can see, Blanca, there are some questions ready, so let's get to them right away. Okay.
Perfect.
So is it possible to use SNP-based NIPT in an egg donation cycle, given the donation is anonymous?
Okay. This is a limitation of the SNP-based NIPT. The SNP-based NIPT uses the maternal profile and the paternal profile to compare them because, as we know, the features would have a combination of maternal and paternal profile. In this case, the maternal genetic load will be the egg donor genetic load. So it would be possible, but it's a tricky field because we will have 3 different sources of DNA in maternal blood. Because in maternal blood we will have the DNA from maternal blood cells itself and fetal DNA that will have half of its paternal pattern and half of the egg donor's pattern. So theoretically, it can be done, but it's now, as I said, a limitation of the SNP-based NIPT. But it can be always done in the NGS NIPT.
Pablo, for your very first question, and of course for your answer to that as well. Now let's have a look. Marta has another question. Great lecture. I would like to clarify, why is sexual chromosomes sensibility lower than other chromosomes? Thanks.
Okay, this question is a really good question. Well, it is mainly because the conditions due to sex chromosomes are less common in the population than those due to other chromosomes. Sensitivity is calculated by the percentage of positives that are real positives. So when we have a lot of positives that can be confirmed by an invasive procedure, we have a high sensitivity. That is why the sensitivity is lower than with other trisomies, like the 21, which causes Down syndrome, because Down syndrome is really common within other aneuploidies, and we don't really have much sex chromosome aneuploidies indeed. So even if we tried, when we tried to make a theoretical sensitivity calculation, when we tried, it had been higher than the real one, because the real one is based on the actual cases that we have, and actually we don't have that much cases, so that's why it is lower than the sensitivity for autosomes.
Excellent. Thank you so much, of course, once more for your question and your help with this. Babel has added one more question. When using NGS, will chromosomes be checked for aneuploidies or only sex chromosomes 13, 18, 21?
Well, when using NGS, you can check every chromosome. When using NGS, you can check also the chromosomes 13, 18, and 21, which causes the most common aneuploidies related to autosomes, but you can also check the sex chromosomes. As I said, answering Martha's question, the sensitivity for each chromosome will vary because the sex chromosome, as I said, are not that common, but every chromosome can be checked, of course.
Thank you again for answering that question once more. Here, more questions are coming in. So how much fetal DNA is needed for NIPT?
Okay, that's a tricky question. It's difficult to know how much, like in quantity. We can't say how much cells that have suffered from lysis and have extracted the DNA, and they are the cell-free DNA we need. What we can calculate is how much fetal fraction we need in blood. And for SAFEBABY, it's a 3.5% of fetal fraction. But also, cell-free DNA can be detected within since 5 weeks of pregnancy, if I'm not wrong, since 5 weeks of pregnancy. So it can be detected, but until 9th week of pregnancy, we can't really calculate if the risk, if we are having an aneuploidy on the embryo, of if the differences in each chromosome are due to a low fetal fraction. So for answering your question, for SAFEBABY, it's at 3.5% of fetal fraction.
Thank you so much for the clarification to this definitely interesting question as well. All right, let's have a look. Okay, next question. So does NIPT tests show gender?
Okay, always the test or the test can test the sexual chromosome, but the gender will be only revealed if the patient wants to know it. We can test the sex chromosome and tell the patient that they are normal or abnormal, but if the patient doesn't want to know the gender, we can not reveal it. We know the gender of the fetus because the mother is always XX. So if we don't have any copy of the Y chromosome, we assume that we are having a female XX, and if we have one copy of the Y chromosome, we assume that we are having a male XY. This is a good question, and it's difficult when we are having twin pregnancies, because when we are having twin pregnancies, it's difficult to distinguish if we have the two of the fetus being males. But we can, when we have Y copies, we can say that we have at least one male, but we cannot distinguish the second one. We cannot say if both of them are males or if you have one male and one female. I hope this answers your question.
Right, definitely interesting. Once again, interesting answer here. And actually, there is a question on twin pregnancies, so let's have a look. Is NIPT a possible screening tool in twin pregnancies?
Yes, as I said, it's possible. It's I would recommend you to, if you're looking for an NIPT and you have had a twin pregnancy or in your family you have twin brothers, to look for an NIPT that uses NGS technologies, because NGS it's prepared for these kind of situations when we have a third source of DNA material. As I said, it's possible, of course, and the only tricky part is that we cannot really distinguish the sex. We can distinguish if we have high risk of fetal aneuploidies, but we cannot distinguish if one is male and the other is female, or both of them are males. Also, if we have a high risk on any of the chromosomes, even the sexual ones, we cannot really distinguish which of the fetus is the one that is affected. It's really, but you can't, of course, do an NIPT.
Thank you so much for yet another thorough explanation to this one. Let's have a look. A few questions are right here. And actually, next one I will not read out. You can see it for yourself, and I'm sure you can read it better than I do. So go ahead.
Yeah. Okay. I don't really know the numbers about the detection. He's talking about the detection of XXY, having two copies of the X chromosome and one copy of the Y chromosome. I don't really have the numbers, but as I said, the specificity of the test is really high for the sexual chromosomes, and the sensitivity is a bit lower than for the autosomes, but it's it's really high. So indeed, you have more than an 83% of the cases of the positives aneuploidies detected by NIPT are confirmed by an invasive procedure. So we can extrapolate that the 83%, which is not a real number, 83% of the XXY maybe are confirmed by an invasive procedure based on the data of the sexual chromosomes.
Thank you so much, Derek, for your question. Of course, indeed, and your help. And so, can the NIPT test be wrong?
Okay, that's an interesting question, Emma. NIPT can be wrong, but it can be wrong very minimum times. As I said, it can be comparable to invasive procedures because the positive predictive value is really high. It's 99.9%, which is even the maximum. But always it has to be confirmed by an invasive procedure. This is because we cannot really separate the DNA coming from the mother and the DNA coming from the fetus. So we are doing math calculations to know if the fetus has an aneuploidy or has high risk of having an aneuploidy. And it's important that we talk in these terms of risk of having aneuploidies, because, as I said, every high risk result on NIPT has to be confirmed. That doesn't mean that NIPT has, as I said, a high positive predictive value, and I will totally recommend to do it before an invasive procedure.
It's another interesting question, so thanks a lot for that. And let's have a look. More questions are coming in. Is NIPT the same test as what is called the Harmony test in the UK?
Yeah, I think the Harmony test is a commercial name for an NIPT, which is the NIPT is the technique. We can say that, and the Harmony test is a commercial name for one test offered in the UK.
All right, thank you so much for the clarification. And let's have a look. We have another question. Can you explain what SNP is?
Okay, the SNP is a single nucleotide polymorphism. For one, I think the audience is not familiar with this term. In the DNA, we have a number of bases, pair of bases that are named after letters that are A, C, G, T. Normally we have a sequence of these letters that are common in all the humans. But sometimes in certain points of the DNA, we have changes that doesn't really affect our life, our development, but are marking every individual. So I have certain letters of my DNA that are different from Caroline and that are different from my sister, but we all can live normally. These SNPs, these bases that are changed, can be used to create patterns that are different in every individual. This is used, for example, for fingerprinting. I don't know if you are used to this term, but when you are trying in forensic science, when you are trying to figure out which was the robber or which was the one that did something, you use this technique to try to find out which one was. So this is a really useful tool to find if the DNA that you are having in maternal blood is actually from the mother or is a mix with the mother one and the father. So that will mean that the DNA that you are having, it's from the fetus. I don't know if it's a complicated question, but I think maybe it's more clear now.
I think it is. So thank you so much for this. Definitely another interesting question, and of course, thank you for explaining. Yes, this is that's why we are, of course, here. So you can see more questions are coming in. So let's have a look at this. Sorry, there is a comment, and the question is here. Until when can you do the NIPT? Is the result more reliable if you wait longer?
I think it's not more reliable. I think the reason of not waiting too much, it's more based on the not making the patient wait for the result. So if you have passed the 9th week of pregnancy and still want to do an NIPT, you can do an NIPT. You also can do an NIPT if you are next to your delivery. But the reason why we are trying to get ahead even the first trimester screening, is that we want to reduce the time of waiting for first information about the fetus. So, of course, you can do NIPT in any time during your pregnancy, and the result is not variable. Of course, it is has been set up for the first, I think, the first trimester, but you can do even after. But I don't see the point of doing it after the second trimester, for example, because then you have been doing echographies, ultrasounds, so maybe you have more information. And if it's like a second test, if you go for an NIPT because your clinician has seen an abnormality in the ecography on an abnormal level of hormones, of course, go for it. But if you have a normal pregnancy and you are like in, I don't know, in your second or even third trimester, I don't see the point of doing it to wait that longer. I will recommend you to do it in the first trimester, of course.
Great. Again, thank you so much. And there are like 2 questions from Tutsi. So let's have a look. Okay. So if you find out at 20 weeks that your baby is abnormal, do you have the opportunity to have an abortion, or is it too late?
Okay, not sure. I think the law about pregnancy termination, it's different in every country, and I'm not really sure to answer you this question because I'm not really prepared about this topic, the pregnancy termination. Of course, NIPT helps patients not to be in this situation, not to be in the 20th week of pregnancy and find out that your baby is abnormal. If you can be in the 9th week of pregnancy and do a test that tells you if you have a high risk, then you can then do an amniocentesis or choriocentesis, and you will be ahead of this situation. I don't know if this information helps, but I'm sorry I cannot really tell you if this is legal or is too late. Sorry.
Of course, that's perfectly understandable. So still, thank you so much for that. And there's one more, okay? Possibly our final question. So if you have any more questions, go ahead and type those in the chat section. And so how much does the NIPT cost, and can it be done remotely by sending blood?
Also cannot answer you about the cost because I'm in the lab part, but I will be glad to type on the chat the contact to contact our commercial department, and of course you can do it remotely by sending blood. The only thing that you need is to find a clinic or a nurse that extracts your blood in a streak cell-free DNA. If you contact iGLS, we can send you a kit with the tube and all the information. So you only have to find a clinic where they use this tube to extract your blood, and of course it can be done remotely.
Thanks a lot for the clarification to this one as well. And yes, if Blanca, if you can type the email address, so anyone, if you would like to get in touch with Blanca and her team, I'm sure they will be more than happy to help. Someone is typing, I want to, oh yeah, that was you, sorry. So there are some thank yous. I believe we will be finishing for today, but now you know that if you have any other questions, you know what to do. You can simply get in touch with Blanca, and I'm sure they will be happy to help you with any questions that you might have. So yes, before we finish, I want you to see that there are some thank yous, of course, for you and your presentation. An amazing presentation. Thanks so much also for clarifying my questions. Hope I will need an NIPT soon. Fingers crossed for sure. Then in such case, best of luck, Bubble. Thanks for answering my question. Very useful. Great presentation. So indeed, thank you so much, Blanca. I think it's been very, very useful to everyone. Thank you for your questions. Because of course, without your questions, we will not be here, first of all, but also you are making it interesting as well, thanks to the questions. And before we finish, Blanca, anything else you would like to add?
No, it has been very nice to know the questions of the patients, because here in the lab we are normally apart from them, and we don't know what are they thinking about the tests. So it has been really nice.
Have to agree that it's really good to be able to, let's say, connect, yes, patients with specialists, especially I think in the lab, yes, because of course doctors have more ways to be in touch with patients, and it's more difficult for you. So it's always a nice thing to do. Thank you, everyone. Thank you, Blanca, for spending this evening with us as well, especially that it's a Friday evening. So now all I can say, have a lovely evening, everyone, but also have a wonderful weekend. Hopefully it will be a sunny and really, really relaxing weekend to everyone. And of course, as you know, we will be back here on Monday. We have actually 2 webinars, so plenty of new topics are coming up again. So I hope that you will be able to join us. And as you know, this has been recorded. You will have a chance to have a look at it on our site, My IVF Answers. And if you go to YouTube channel, there are plenty of previous webinars available, so I can only encourage you to check it out. Thank you so much. Take care. Blanca again. It's been a pleasure to have you here. Take care. Bye-bye.